Good afternoon, everyone. I am Arjun Jayaraj from the Range Center for Venous and Lymphatic Disease in Jackson, Mississippi, and my talk today is cross-sectional area should guide iliac vein stenting. I would like to thank Dr. Walker and the NCVH for the opportunity to contribute to the digital education series. Thank you. I have no financial disclosures relevant to this talk. The important question that needs to be posed with regards to this talk is what the ideal caliber of venous stents in the iliofemoral system should be. The simple answer to that is that they should be reflective of normal venous caliber. In order to answer this question, we used multiple techniques: the distribution curve of IVUS planimetric data, the Poiseuille equation, as well as Young's scaling rule. The distribution curve of IVUS planimetric data evaluated 345 limbs with chronic venous insufficiency. These patients had a median age of 60 years. There was a preponderance of women. Post-thrombotic syndrome was the most common pathology, and the left side was the more common of the two sides. We then computed the luminal area of the common and external iliac veins for these 345 limbs and then plotted them. The principle behind this particular technique is that if the IVUS luminal area follows a normal distribution, then the right tail of the curve, that is a z-score of 1.65 or more, should approach normal values per the distribution theory. So when we plotted the common iliac vein, this is what we got. It's a normal curve, and in the z-score of 1.65 corresponded to a luminal area of 203 millimeters squared. About 16 patients had a luminal area of 203 millimeters squared, and overall, the range went from 203 to 290 millimeters squared with a median common iliac vein luminal area of 220 millimeters squared. Correspondingly, the median diameter in the common iliac vein was 17 millimeters. When we plotted the same for the external iliac vein, we got a normal distribution here as well. Here, the z-score of 1.65 corresponded to 171 millimeters squared, and there were 21 limbs that had this particular luminal area. Correspondingly, the range went from 171 to 277 millimeters squared with a median of 183, and the median diameter corresponded to 15 millimeters squared. So these are the normal luminal diameter and areas for the common and external iliac veins using this particular technique. Now, Poiseuille equation, as we all know, demonstrates the relationship between flow, pressure gradient, and resistance. And resistance can be broken down taking into account the length of the vein, viscosity of blood, and the radius. Now we know that pelvic and lower limb arterial flow is roughly 1,500 cc's per minute in normal individuals at rest. So this would assume that the same amount of blood flow has to go back through the veins. Correspondingly, each common iliac vein outflow would be roughly 750 cc's per minute. We know the length of the common iliac vein is 4 centimeters and the viscosity is 0.04 poise. Now, when we take into account an optimum stent diameter, it should be one that yields a negligible gradient across the stent length and should also have enough margin to spare to account for the 3 to 5 times increased flow that occurs during exercise, or margin to spare for stent reintervention. So when we plotted different stent diameters with resting, exercise flow, and diameter stenosis, this is sort of the pressure gradient that we got. And if you try to keep the pressure gradient across the 4 centimeter segment of common iliac vein, a half a millimeter or so, then you end up with a stent size of roughly 18 millimeters. Young's scaling rule essentially gives us the relationship between parent to daughter branches. It is something that is applicable in multiple trees, the bronchial tree as well as the vascular system, for example. And essentially, it says that the parent diameter would be roughly 1.26 times that of the daughter branch. It's a fundamental law of efficient branching to maximize flow with the least expenditure of energy. The caliber of iliac vein segments can be projected using the scaling rule from known common femoral vein caliber, and the projections yield the upper limit of upscaling required of the parent vein. We used Dr. Fronik's work that showed that the common femoral vein diameter is roughly 12 millimeters. So when you scale up to the external iliac vein, it should be 15, and upscaling for the common iliac vein gives us a diameter of 19 millimeters. When we put all this together, these are the different numbers that we get from the IVUS planimetric data, the Boyce-Hughes law, as well as the Young scaling rule. Distilling all this, the vein size in the common femoral, external iliac, and common iliac should be roughly 12, 14, and 16 millimeters. Correspondingly, the area would be roughly 125, 150, and 200 millimeters squared. Having said that, it is important to individualize stenting, paying close attention to inflow and IVUS luminal areas. Now we know that these are what the ideal vein diameter and luminal area should be. The next question we need to pose is that whether these numbers should be derived, i.e. stenosis be determined using venography or IVUS. And there are a number of publications that have looked at this. This is the video trial paper that compared venography versus IVUS for diagnosis and treatment of iliofemoral venous obstruction. This is from our own group that was published last year, and this is from the NYU group. Essentially, what these papers and multiple others demonstrate is that IVUS is superior to venography in the diagnosis and treatment of iliofemoral venous obstruction. So we know we need to use IVUS to identify or determine stenosis. And here I want to say a few words about diagnosis of stenosis. Now, an often used technique of stenosis determination is comparison to the ipsilateral normal vein diameter below. The problem with this particular technique is that one can encounter what is called a long segment stenosis or a Rokitansky lesion. And this is an example of the same. You'll see that there is diffuse stenosis of the external iliac vein. And so if you were to compare the common iliac vein there with the external iliac vein below it, then the common iliac vein is considered normal. However, you'll notice that the common femoral vein, indicated by the blue arrow, is larger. So this particular patient has stenosis in both the external as well as the common iliac veins. And so use of this particular technique will lead us to erroneous conclusions. The other problem with using this particular technique is that skip lesions are not uncommon in chronic iliac vein obstruction. In fact, when you combine Rokitansky and skip lesions, up to 20% of patients presenting with post-thrombotic syndrome can have these lesions. And this is an example. Here again, I've marked out the common iliac and the common femoral vein, and you'll notice that there's stenosis in these two segments. However, the segment in between the two is normal appearing. So again, it is important not to use these techniques for determination of stenosis. Another technique that is often used or that is sometimes used is comparison to the opposite side iliac vein. Now, this is an example of a coronal view of a three-dimensional reconstruction from a CT venogram. And I call your attention to the distal common iliac and the external iliac veins on both sides, and there is significant stenosis. So if one were to compare one side with the other, then it would come out as being normal. So, and in fact, bilateral obstruction can be seen in more than 10% of patients presenting with chronic venous insufficiency. Depending on the paper one reads, it can go up to 13 to 15% as well or higher. So stenosis should be determined by use of minimal normal IVUS diameters or luminal areas and not the normal ipsilateral or the contralateral vein. So now we've established what should be used and the fact that IVUS should be used. Now the key question to ask is, should we use diameters or luminal areas, which essence is what this talk is all about. Now here is an example of planimetric evaluation of the common iliac vein. The luminal area has been marked out, and you'll notice it is pretty straightforward. It gives us an area of 116 millimeters squared. And for the common iliac vein, the ideal luminal area should be 200 millimeters squared. So there is clearly significant stenosis in the common iliac vein. And this is the luminal area. Now, if the vein were to be a circle or close to a circle, then it would be easy to compute the diameter. And here it is 9.2 and 8.7. And in the common iliac vein, it's certainly a stenotic because, as we said before, it should be roughly 16 millimeters or more. However, what if we were to encounter a non-circular iliac or a femoral vein? So do we use this to compute this diameter to compute stenosis, or do we use this diameter to compute stenosis, or do we look at the major axis, or should we add the major axis to the minor axis and average it to get the diameter? So using diameter for determining the degree of stenosis is not easy and can lead to confusing results. IVUS lumen area is easier to compute and more accurate than diameter. And in fact, this lumen area doesn't apply to IVUS alone, and it can actually apply to CT venograms as well. And this is a paper that was recently from a group that was recently accepted. And essentially, we compared the minimal luminal areas of the common iliac, external iliac, common femoral veins obtained on 3D CT venogram with IVUS. And we found that there was very good correlation between IVUS and 3D CT venogram for luminal areas. The sensitivity actually ranged from 80 to 100% depending on the segment that was evaluated. Specificity was also pretty good, and accuracy ranged from 82 to 91%, depending on the common femoral, external iliac, or common iliac veins that were evaluated. So the luminal area concept applies not only to IVUS, but also to 3D reconstructions of CT venogram. And this highlights the utility of minimal normal areas, normal luminal areas with regards to both 3D CT venogram and IVUS. In essence, IVUS is essential for the diagnosis and treatment of femoroiliocaval obstructive pathology. Stenosis should be determined by use of minimal normal IVUS luminal areas. Diagnosis of stenosis by venogram or comparison to ipsilateral contralateral vein is prone to error. It is important to tailor stenting to the individual patient. And in patients with recurrent symptoms, use of IVUS luminal areas can help determine necessity for intervention. Thank you very much.